Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Courtney Smith. Today's episode features an expert discussion of the burden of HIV among BIPOC and migrant communities, as well as key strategies to reduce racial disparities in HIV care globally. This episode is part of a larger educational program titled Tackling Racial Disparities in Care for HIV and Viral Hepatitis. During this podcast, Dr. Dhairyawan and Solange Baptiste will discuss the disproportionate impact of HIV, barriers to HIV services, as well as strategies to overcome health system and provider-based barriers to engagement with HIV care among BIPOC communities and migrant populations. For more information on Dr. Dhairyawan and Solange Baptiste, along with a link to the complete program, including a downloadable slide set, please visit the show notes for this episode. Now let's get started and hear what the experts have to say on this important topic.
Thank you very much, Courtney, and hello and good afternoon, good evening, good morning to everyone. We just want to do a quick scan of why we've gathered today and the program overview, looking at the disproportionate impact of HIV among Black, Indigenous, and people of color communities and migrant populations globally. We're looking at barriers to HIV testing, prevention, and treatment services among these communities and migrant populations, and also looking at strategies, right? So how can we overcome health system-based and provider-based barriers to engagement with HIV care? So jumping right in, we're looking at the disproportionate impact of HIV among BIPOC communities and migrant populations. This slide shows a snapshot of the global HIV epidemic by region, and it is quite startling. If you look at it, you see this global overview, you will see that the regions where Black, Indigenous, and people of color live have worse rates than those without. In fact, if you look at the red, you will see that about 58% of new infections are in the African region, which is quite telling about the access to good quality barriers that we have. This slide is also showing that the issue is not specific to high income or low income countries or specific regions of the world, but really have to go and dig deeper. This slide is looking at PrEP coverage among eligible adults by race, ethnicity group in the United States, and this is from 2019, so pretty recent. You'll see here that even obviously in high income countries like the United States, race still affects PrEP coverage. This data demonstrates that PrEP coverage is almost 8 times better for white patients than for Black patients. Which brings us to the next question of what determines good health. And sometimes we need to zoom out a bit in order to kind of think about what is the real issue that we're talking about. And if you start to think about what determines good health, the usual suspects come to mind, which are the ones listed on the left. You kind of think, first of all, especially if you're coming from a clinical perspective, you start with genetics, you think of nutrition, lifestyle, environment, access to healthcare, social support systems also play a factor in terms of social capital. If you also think about all of the ones in the brackets, which are under genetics, nutrition, lifestyle, environment, access, and social support, you can think of these as rooted in social determinants, meaning these things are all factors that are rooted in the social construct of our society. And there are various factors that can relate to what these outcomes can look like, from economic stability, social and community context, neighborhood and the environment, healthcare, education, all have social factors that influence, as well as race. So that's just kind of helping to situate race in the context of social determinants of health. Over to Rageshri.
Thanks so much, Solange. And hello, everybody. Thank you so much for the invite. So I think we've really talked a lot about racial health inequalities, particularly during COVID. I think it's really got people thinking about them, but I think it's really important to understand that, of course, they existed long before COVID. And these are just some statistics from the UK, where I'm based, which shows many different aspects of health, in which, compared to white British people, Black and brown people are more likely to have poorer health outcomes. And when we think about HIV in particular, I'm going to look at 2 high-income countries. So looking firstly at the UK, we can see their racial inequalities in HIV here. So, for example, we know that in 2018, 74% of heterosexual people receiving HIV care were from racially minoritized groups, and they're more likely to be diagnosed late, more likely to experience viral rebound and spend less time engaged in care. And we also know that although it's great that new HIV diagnoses are mainly going down, particularly amongst white MSM, they're decreasing more slowly amongst racially minoritized MSM. So we still have work to do. And then when we look at the US, you can see that we have racial inequalities there as well. So in 2018, for example, despite making up only 13% of the population, Black people made up 42% of new HIV diagnoses, and Hispanic and Black MSM accounted for 55% of all new HIV diagnoses. We also know that Black and African American people living with HIV were less likely to be engaged in care, less likely to be virally suppressed, and less likely to receive timely antiretroviral medication, although there has been some improvement in this recently, which is good to see. So when we think about reasons for racial health inequalities, when we hear conversations amongst the general public and often within the health field, there are two commonly cited reasons for these inequalities. So one hypothesis is that it's a cultural issue and it's the way in which racially minoritized groups behave that makes them more susceptible to disease. Or two, it's a genetic thing and there are innate genetic differences that make racially minoritized groups more susceptible to disease. But however, when we think of this, it makes me think of the deficit model, which comes from sociology. And what this does is that it blames the individual or minoritized group instead of the societal structures and processes at the root. So essentially, it's a form of victim blaming. And what I'm going to do now is explain why these hypotheses are untrue. And I'm not going to spend much time talking about cultural, except to say that actually the way in which racially minoritized groups may behave is due to structural issues in their lives. So for example, with COVID, we know that they may have increased rates of COVID, but that's because they're more likely to live in overcrowded housing, more likely to work in occupations which are public facing. So it's not that they choose to behave in that way, but it's the structural issues that mean they're more susceptible to COVID, for example. So let's move on to talk about, is it a genetic thing? So to really answer this question, we need to look back in time and think about the origins of where our ideas of race and racial hierarchy come from. And although we know there have been ideas of racial groups around for a long time, they weren't really written down until the 18th century. And Carl Linnaeus, who's a Swedish botanist, wrote in a book in 1735 different categories of human beings, and he assigned racial groups to humans. And he had a history of doing this. So he also liked to categorize plants, he liked to categorize animals, and he was first to write down racial categories for humans. And what he did was to ascribe different physical or behavioral characteristics to each group of humans. So what he did was to put people into different groups. But not only did he put them into groups, he also ranked the groups. So this was a ranking or a hierarchy. And he ranked groups with the white Europeans being at the top and the other groups being more inferior downwards from white Europeans. And it's important to understand that not only did he look at physical characteristics, he also assumed different behavioral characteristics to each group. So this was about racist assumptions about how different groups behaved. And this hierarchy is a really important thing because it implies value, and it means that some human groups have more value than others. So white Europeans, perhaps he viewed them as being more intelligent, behaving better, as well as being more beautiful. And there's no coincidence really that this was happening in the 18th century when there was a lot of European colonial expansion happening and European countries were taking over whole lands and peoples. And this idea that some groups of humans are less human than others really justified the dehumanization and subjugation of different populations at the time. So for example, the transatlantic slavery trade and the genocide of indigenous populations. So this is a quote that I really love from Gary Young, who's a journalist in the UK, saying that race is a nonsense, but a very real nonsense. So race is a nonsense because it's a social category. It came from racist ideas. So racism led to the creation of race, but it's a very real nonsense because the impact of race is racism, which obviously has very large impacts on many people around the world. So as I said, race is a social category. There's no genetic basis for race. And this was really proven with the Human Genome Project, which when it reported at the end of the last century, showed that of course there are genetic differences between different populations, but they didn't match racial categories. And actually there's more genetic diversity shown within races than between them. So really race is a poor proxy for ancestry. And we also know that race is a social category because categories of race have changed over time. So for example, when people moved to the US, when they got to Ellis Island, they were assigned racial categories. And at that time, Irish people and Italians were not deemed to be white. So they weren't put into the white racial group. And that was because it was felt that their behavior wasn't good enough to be deemed as white. And it took a while for them to attain whiteness. So despite race and ethnicity being social categories in medicine, unfortunately, it's often used as a biological category. And we sometimes see race being used as a biological category in our clinical treatment algorithms and diagnostic algorithms. So let's talk about what does cause these actual racial inequalities in health. Let's talk about barriers, for example, to HIV testing, prevention and treatment services. So what is at the cause? If it's not a genetic thing and it's not the way in which people behave, what does cause these huge health inequalities? Well, the main cause is structural racism. And this is quite a nice definition here. So structural racism is the processes of racism that are embedded in laws, policies and practices of societies and its institutions that provide advantages to ethnic groups deemed as superior, while differentially oppressing, disadvantaging or otherwise neglecting ethnic groups viewed as inferior. So it's not an interpersonal racism. It's not one person saying a racist thing to the other or showing prejudice. It's ingrained within our societal structures. And structural racism is experienced throughout the life course. So we know, for example, that it affects the social determinants of health that Solange was talking about. So, for example, education, poverty, employment, housing, incarceration, and social exclusion. And when we look specifically at access to healthcare, we need to think about how we make healthcare hard to reach for some racially minoritized groups. So, for example, do we have the right information in a variety of languages? Do we have interpreters? And do we have resources that are culturally specific, so accessible to many different groups? And most importantly, are we involving racially minoritized communities in the planning, delivering, and evaluation of our healthcare services? We also know that hostile immigration environments around the world also put people off from accessing care. And I'm just going to, there's a photo on there, which is the report from the National AIDS Trust in the UK, which interviewed migrants living with HIV last year. And it showed that these hostile immigration environments can have a real impact on people's health outcomes. And for example, we also know in the US, access to health insurance is a really important thing in terms of accessing care. And once people get into healthcare, we need to think about patient experience and how racism can affect engagement in care. So I'm going to talk to you very briefly about a concept that comes from philosophy called testimonial injustice. And this is a type of epistemic injustice or wrongdoing related to knowledge. And basically what this means is that because of societal stereotypes, some groups are less likely to be taken seriously or believed when they speak. They basically experience what's known as a credibility deficit, so they're not taken seriously. And this tends to happen often to women and to racially minoritized groups. And it's important in healthcare because when patients are talking to their doctor and they feel that their concerns are not being addressed or taken seriously, it can mean that they're dismissed and it may put them off from telling their doctor in the future what's really going on. And we do know that repeated experiences of testimonial injustice may put people off from talking to their doctors about what's really happening. So they may self-censor. And when I think of an example in HIV care, the most prominent example for me is around antiretroviral adherence. So if you're a patient and you think that perhaps my doctor's not taking what I'm saying very seriously, so I'm having some side effects from my medication, for example, and if you're continually doing that and continually being dismissed or seen as not credible, it may put you off from telling your doctor more about your antiretroviral side effects. And we do see that, for example, in patients who have come off their HIV medication with very high viral loads indicating that they've come off their medication, and yet they're telling their doctor that they're still taking their medication. So those repeated experiences of not being taken seriously means they may not tell their doctor the truth, and it means they may be less likely to engage in HIV care. So I'm going to move on now and pass on to Solange for the next bit.
Yes, we're doing a duet here. It's impossible to talk about racial inequalities and not talk about power imbalances and race together. I was just thinking as Rageshri was talking about some of the testimonial injustice and the credibility bias. And I remember in the early 80s, at the start of the HIV epidemic, there was a lot of conversation about how to get medicines to the continent of Africa. And a lot of discussion around access in terms of best medicines, better pricing, but also, there was this pervasive thinking that Africans can't tell time. Even at a more population level, this sort of testimonial bias or this bias that, okay, well, they're supposed to take the medicines, these intervals during the day, and will it really work for these people? And you will see a lot of that in the thread here. So obviously, it's not only a US problem. We've had good examples throughout the session thus far from high-income countries, not just within regions where there are more BIPOC populations. But if you think about the individual bias and the system bias, we think about the personal interaction with race, but also the institutional problems that there are. And I wanted to introduce the term recipients of care, not just patients, to kind of have a wider view of the thought about how race affects people's access to care. So we often in HIV go through the cascade and talk about those who are being tested or those who are being linked to care, but there's a whole sort of catchment area of just never engaged with the health system. And we have to think about that as those who should be receiving care and may not be receiving care for several different reasons. And our interventions, as Rageshri talked about at the start, can also kind of be in the victim blaming land. So the patient, the recipient, they're not doing enough. But also we need to also think about interventions within the system as well as within healthcare professionals to understand and unpack what's really happening. And there has been this sort of normalization of inequities. It is just how things are. I mean, goodness, can we really change the system? That's just how it is. And we see it right now with COVID, where there's been hoarding and access to vaccines. I mean, I'm sitting in South Africa, so people here are waiting for their first vaccine shot. But in other higher income countries, we are seeing people, getting their third booster and all sorts of other access things that we are struggling with here. So HIV is really an interesting disease to use as an entry point for understanding race, racial inequalities, because it sits sort of on this knife edge of medicine and politics. And it's usually a very good entry point to understanding how race can help how race plays out. And we're thinking here specifically within the public health system and those that are reliant on a free public health system. And this was already touched on before, but overt stigma and discrimination at health delivery sites are some of the examples of not being offered the best available treatment. Your symptoms get unchecked, especially as Rageshri said, women and people of color tend to, when they talk about their symptoms, the higher tolerance for pain, not really believing the credibility issues, which really then turn into these discriminatory practices, long wait times for pain medicine, denied timely access to services, not referred to specialists. And it's interesting because we also have to think about what it is we're tracking, and we track what we value. So we'd be able to quote some sort of randomized control trial or something from a journal article and say, according to so-and-so et al., this is what we see. But the data that comes from communities themselves, from recipients of care, from patients in the public health system is often a missing voice.
Thank you. So I'm just jumping in here just to talk about one other way in which racism can really impact on health outcomes. And this is really about how racism gets under the skin. And this is something that is being increasingly talked about and researched at the moment. So if you haven't heard of it, you might hear of it in the next few years. So we know that when we get stressed, our body's response is essentially to flee or to fight. And when we're chronically stressed, that response is chronically activated. And what happens in the body is that our blood pressure goes up, our heart starts beating faster, our body releases sugar into the bloodstream and fats. And if it's chronically activated, those things are happening all the time. And this can really increase, for example, people's likelihood of getting diabetes or metabolic syndrome or hypertension. And it's thought that racism can provide that kind of everyday stress, which chronically activates the physiological response. So this kind of everyday racism. And it's thought that this causes a kind of weathering or early aging. And it's thought to be due to the cumulative effect of economic, psychosocial, physical, and chemical stresses, plus interpersonal discrimination. So there is a lot of studies being done about that, on how racism itself can literally get under the skin. So I'm going to pass over to Solange now.
Yes, so that is interesting. And I think as we continue to think about the HIV cascade, and we think from testing all the way to viral suppression, we often think about that in a very linear way. So if you are a person of color and you are in a sort of an environment where you're experiencing racism and you have HIV and you're in this linear cascade, it's not exactly reality, right? The lived experience looks very different, which is why the cyclical cascade is quite an interesting thing if you haven't seen it as yet. And what we're looking at here are, as you know, periods of engagement and re-engagement. People say they get an HIV positive result, they get linked to care, but then they never really show up to actually get the medicines, or they start and then for several reasons, there are different reasons that determine why people engage and re-engage. But the idea is to minimize the frequency and duration of the periods of disengagement rather than to blame them and say, what is wrong with you? Why aren't you coming and staying on your treatment? And one of the critical factors to think about here is quality. Often people are not coming back for services or desiring to link to treatment or services because of the quality. This study here is from The Lancet, is a systematic analysis of excess deaths due to conditions amenable to healthcare interventions in 137 low and middle income countries. And among the over 800 plus healthcare related deaths in West Sub-Saharan Africa, 43.6% were due to poor quality of services. So if you look at the pie chart, you will see the deaths due to not using the services and then the deaths due to poor quality services, saying that it almost doesn't really matter if you stay at home, your outcome might be the same, which is why often many people are don't engage with the public health system unless you feel terribly unwell, which is why we still have a problem with advanced HIV disease and people showing up very, very, very ill. Handing over now to Courtney.
Thank you, Solange. Now we will listen to audio clips from Susan, an activist and patient advocate sharing experiences on disparities in HIV care globally and ways in which those barriers can be reduced. The first question is, how has provider or healthcare system bias affected your HIV care or the HIV care of someone you know?
One person that I've worked with shared a particularly harrowing experience with me, that she had been on antidepressants for some time and was keen to come off, but her doctor said to her, well, I hear that, Black women, you're much more likely to have mental health problems. So if you come off your medication, you'll probably be taken against your will into a psychiatric hospital and your children may be taken into care. I do keep hearing these types of experiences by Black women in particular.
The second question is, what advice do you have for healthcare professionals for providing culturally appropriate HIV care to reduce racial disparities?
In the UK, I think initially it's really important to have zero tolerance of the stigma and discrimination that people of colour often experience. I believe that very often the systemic racism is the root cause of much of the discrimination that we face. So I think it's important that that's recognised and that healthcare providers stay aware of this and continue to have training on this to try and address it. And I think there also needs to be much more of a focus on quality of life. We people with HIV, so much more than our CD4 count and our viral loads, and very often people of colour may be facing intersecting challenges that's impacting on their quality of life. Someone may be experiencing, for instance, immigration issues, other experiences of racism. All of that may impact on their engagement in care, taking their medication correctly. It's very important that healthcare professionals conscious of that to ensure that people of colour are receiving the best quality of care.
It is my great pleasure to turn things back over to Solange, one of our faculty speakers.
Thanks very much. So now we'll move into looking at strategies to overcome barriers to engagement with HIV care. I would often ask the question of where do you get your data source? If you think as a member of the audience in the session listening to me and Rageshri, where do you rely on? Where is your source of data when you're thinking about the work that you do in HIV? If you listen to the government, researchers, providers, program implementers, and affected community, the data source is often overwhelmingly the traditional academic science. I'm sure each of you would be able to quote a journal article or talk about what maybe government report was issued, what the UN, the WHO references is coming from the government, or it's coming from an academic resource. But there's an often missing piece of information, which I talked about earlier when we're speaking about, tracking what we value and therefore measuring what it is we value. So the citizen science, or the information and the data that comes from citizens or recipients of care. So what is this citizen science? It's not specific to ITPC, and it's obviously not specific to HIV or health, but it has been used before. And you will if you think about the recent COVID tracking, they also spoke about citizen science in terms of surveillance. I believe it was in the US, if it can trigger your memory. But citizen science is really trying to move from this idea of being the researched upon or data extraction. So let's go see what's happening in this population. Let's go to this particular clinic. Let's go to this site. But rather seeing a switch to more data democracy, combining community-led interventions, implementation science, and life mapping, which is really looking at the lived experiences of people. So put together all sort of in the stew pot, which you see there, funneling out to be able to get to citizen science, and then using that information and that data aggregated to be able to affect targeted action or advocacy. It acknowledges that people are experts in their own lives, and it pivots away from the notion that academic research and analysis is the only legitimate way to create knowledge. The name signals democratization of data collection and analysis, empowering participants and respecting their expertise. Community-led monitoring is a process by which communities take the lead to routinely monitor an issue that matters to them, right? So this is where communities are leading the process. They're identifying their top priorities or the pain points, whatever it may be, whether it's return of viral load tests, how long does it take to be used with the clinician for decision-making rather than the time it takes to get to the lab? What are the indicators that make sense to them that addresses their pain points? Not what PEPFAR wants, what Global Fund wants, what the clinic needs. And they collect this data, and then they analyze the results, and they share the insights from that data with a larger group of stakeholders called the Community Consultative Group, or there's another name, it's a proxy, a group where they sit and discuss, and they say, oh, this one is one-off. This looks like an actual problem. We're seeing a pattern here. And then they work alongside policymakers to co-create solutions. So there's not just finger pointing, even though they're quite capable of that, but also coming with a solution of saying, well, what can we do to solve the problem that has been identified? So when problems are uncovered through the CLM method and they are not resolved, the communities can then escalate with very targeted advocacy and action. Endorsement and validation from healthcare providers are not required. And this is the ITPC model for community-led monitoring. This is one of our sort of ways of our approach as ITPC, but this is widespread now within the global HIV space. It's been recently sort of still in an evolutionary way being worked out in terms of scale up and all of the details, but they all have these same principles. It starts with education, right? You cannot, as a community or recipient of care or group of members in a community, research or do anything if you don't understand the issues. So you need to understand the science behind the disease, but not only the science, but the standards. What's the standard of care? What does the WHO say? What are the normative standards? And what's also in your country, in the National AIDS Program, what are you supposed to be getting as a standard of care? Then there's a documentation of the experiences. Then we move into engagement, and that has a sort of mutually reinforcing with advocacy. You discuss the findings with the stakeholders, such as a community consultative group, sort of analogous to the CCM from the Global Fund, where you can have someone from donor community, recipients of care, government, all sitting at the same table saying, here is the report for the data that has been collected over the past 3 months, and let's talk about what we're seeing. And then that can turn into targeted action or some sort of solution that everyone comes together with. Community-led monitoring definitions. I'm not going to read this out, but you can see that there's a far-reaching multilateral donor and normative agency definition of this CLM, or community-led monitoring, from UNAIDS, PEPFAR, Global Fund, French 5%. And they all have different sort of tweaks on it. You can read the slides later. The aim is to improve health systems by highlighting problems and collecting information on the state of access and quality health services. So this is a short example of the kind of data and the examples of wins that you can have. Community-led monitoring, impact and advocacy wins. This is an example in Sierra Leone. NETHIPS, which is the national network of HIV positives in Sierra Leone, turned key population-specific community treatment observatory data into an advocacy win by securing a signed commitment from the government to develop a differentiated service delivery policy for Sierra Leone. They saw that there was no information disaggregated by key population, brought it to the CCG, and they said, oh, wait, we are supposed to have a DSD policy, and that is what the community was able to push for. I'm not going to read the detail of this, but you can see there's a quote there from Martin, who works at NETHIPS. But the situation here was during COVID times where they did not have data on treatment failure. And they worked in September 2020 to be able to develop a new tool for the new set of service registers to capture treatment failure indicator and that information. Okay, going on. What can CTOs monitor? There's a range of categories, and this is just one framework. CTOs are community treatment observatories, and they are just an observatory where communities are observing, and it's applied to treatment. So observatories can be applied to any indicator: police brutality, government corruption, prevention, stigma in HIV, right? And this is a community treatment observatory. And you're looking here at the categories of availability, accessibility, acceptability, affordability, and appropriateness of HIV care, and applied in various different disease contexts as well. So it's not specific to HIV. As you can see, it's a model. And you can look at the different icons and the different kinds of questions that you can pull out from there. This is an example of data that has been generated from a regional community treatment observatory in West Africa, which was funded by the Global Fund. ITPC in West Africa was able to look at data across 11 countries, and they were able to monitor specific sites in these countries. The results of their community-led monitoring was quite impressive and was part of the story that led us to community-led monitoring, I think, taking a lot of traction with PEPFAR and the Global Fund. If you look in the first row, you're looking at in the monitored sites, all the things that should decrease were decreasing. So frequency of recorded ART, frequency of recorded viral load lab supply, and length of days of ART stockouts, all should be decreasing, and they were in the monitored sites in those periods. And then those things that should be increasing in the monitored sites were increasing: quality of care, viral load tests performed, and viral suppression. So this just goes to show you that there's actual good quality data that can come out of community-led monitoring.
Thank you so much. So thinking about other things that we can do as well to really address racial health inequalities. So I think it does start off with looking at ourselves, and this is really geared towards healthcare professionals. I think it's really important that we reflect on our own implicit and explicit biases. So it's important to realise that we are all products of society. We reflect societal views, and we all have some kind of implicit bias. It's normal, but it's good to be aware of it, and be aware that when we're busy or stressed, we may be more likely to act on our biases. As Solange said earlier, being aware of the power imbalances we've had with our patients and how they may affect the way they engage with us, and make sure that we're really listening actively in consultations and validating our patients' testimony so they're more likely to speak to us in the future. When it comes to training, we need to ensure that not only are we are training about cultural humility, but also structural competencies. So thinking about the structures that really affect a person's ability to be able to engage in healthcare and in good health behaviours. Looking at our medical curriculum, this could be wider. For example, we need to understand the history of medicine, as well as the diversity of people that we serve, and what can we do in our services. So, for example, we can make sure we provide accurate information on entitlement to healthcare, make sure we have interpreters and information in different languages, and really make sure we take a proactive and holistic approach to care of our patients. So thinking about those social determinants that may affect a patient's ability to engage in care. So make sure that once we've identified issues, that we can refer promptly, for example, to mental health services for advice regarding benefits, housing, immigration, refer to peer support. And we need to develop policies that can overcome individual bias. So, for example, opt-out HIV testing is a really good example, where instead of targeting people for testing, we test everybody. And also consider the equity impact of new policies. So really, there's been a shift towards telephone and virtual appointments with COVID, but think, is this appropriate for all of our patients? Do they all have access to technology, for example, to do this? And in policy, we can disaggregate data to focus on individual ethnic groups. sort of large ethnic groups, because of course people are individuals and people behave differently. And we can make sure we commission a variety of ways for which communities can access health services and health information. And then finally, looking at how we do research. And this is a really excellent paper that I would recommend, which is a guide for publishing on racial health inequities. So they talk about going beyond just describing them, but addressing them, understanding that we're measuring racism, not race. And the really important thing is about doing research that is rooted in the community, so community-based participating research, understanding what are the important questions and how to answer them. So we have some take-home points for you, and I provided the first couple. So it's really important that we're not colourblind in our approach to patient care. Racism does affect people and it affects their health. And it's really important to understand that the type of healthcare one receives is predetermined prior to their clinic appointment. So people's health mostly due to social determinants before they reach clinic. And racism is the driver of those social determinants of health. So we need to have a holistic and structural approach to healthcare. Handing over to Solange.
Yeah, and I couldn't agree more. And that community-led monitoring is a critical intervention led by affected communities that contributes to improving health outcomes. So it's complementary. And community data sources should complement traditional academic data to ensure sight of the whole data story and calibrate interventions in HIV care. It's really weird to have any space where you only see the supply side story. You have to hear about the demand side or the recipients of care and hear what they're saying as well.
Thank you.
Thank you to Dr. Rageshri Dhairyawan and Solange Baptiste for that excellent presentation. So what interventions or strategies do you all use or have you used in the past to overcome barriers to optimal HIV care in clinical practice or in the community?
So for me, I think it's really thinking about those social determinants and thinking about how they affect people's life, essentially. They have a huge life outside of clinic, and that's what's impacting on their care. So what can we really do to help with those things that are causing patients to have more difficult lives and worse health outcomes? So as I said, are they having issues, for example, with their immigration status? Is there anything we can do to help with that? Can we refer them for advice? Are they living in poverty or have food insecurity? Is there anything that we can do to help with that? Can we refer to a service? So for me, it's that real holistic individual approach and trying to work out exactly what it is that a patient needs, which may impact on their HIV care and health.
Thank you. And Solange, did you have anything to add?
I was just going to reinforce the point of hearing from the persons who are affected by a particular disease, and particularly in HIV, which I said is a very interesting entry point because, it's quite easy to address issues of HIV, especially since we work in HIV, and forget hypertension and other chronic diseases. And so you see people having to fall off what was a very good trajectory for HIV care and then really suffer bad clinical outcomes for something that's a chronic disease. And so that whole idea of how race interplays with, especially for me, working in a more public health globally view, seeing the intersection with the public health sector and what does free quick care look like and the issues of quality. So being able to really hear from recipients of care and being able to aggregate those voices to actually change a public health system that is already crushing under, the economic strain of COVID is really important to be able to now tease out the racism that is happening within the system.
Thank you very much, Dr. Dhairyawan and Solange Baptiste, and thanks to you, the listeners, for joining us. As a reminder to view the full program, Tackling Racial Disparities in Care for HIV and Viral Hepatitis, and to download the slide set associated with this discussion from the Clinical Care Options website, please click on the link in the show notes. As always, thank you for listening.